Okay, just past 12. So good afternoon, everyone. Welcome to MassConf Research Roundtable Seminar Series. Has been a great journey with everybody walking us through this seminar series. We have heard from many of our internal investigators talking about their research. Today, we're going to have a special treat for everybody. We're welcoming our people from our great partner organization, which is the Pima County Health Department, and come to talk to us about their projects and potential for collaboration. As you all know, one of the major aims for this seminar series is to establish partnership and collaborations across different organizations and between different investigators. And when they're coming in, I saw they're not strangers to our college. And I already see they're hugging and shaking hands with many of our students, faculty, and staff member. So we'll be working very closely with the health department and local county. And today is such a pleasure to welcome Laura Vitkus, who was the program coordinator for Health C Pima County Health Department, and also Bailey Inman, and who is an epidemiologist. I'm an epidemiologist myself as well, and Pima County Health Department. And Betsy Camara, trying my best to pronounce, Office of Heat Response and Relief Program Manager in Pima County Health Department, Emergency Mitigation and Preparedness Division. So they will be doing their individual presentations, and then we'll have a panel discussion at the end. By the way, for people who don't know me, my name is Zhao Chen. I'm professor and associate dean for research in the college. All right. So here are the topics for our future coming up seminar series. So please join us at those days for you to reserve on your calendar. Also a QR code to scan to see more detailed information. For each of the seminar, we would like to hear from our audience about the format and the presentation, as well as their wish for future seminar presentations. So please complete the seminar survey before you leave the room. With that, so Laura, you go first. Yeah, welcome, Laura. Great.
So before we get started, I'd like to read our land acknowledgement. On behalf of Pima County residents, we honor the tribal nations who have served as caretakers of this land from time immemorial and respectfully acknowledge the ancestral homelands of the Tohono O'odham Nation and the multimillennial presence of the Pasquayaqui tribe within Pima County. Consistent with Pima County's commitment to diversity and inclusion, we strive toward building equal partner relationships with Arizona's tribal nations. So thank you all for being here today. I'm delighted to come back to my alma mater and present. I'm a graduate from 2018 with my MPH. And I will be talking about our CHNA and our CHIP. So Pima County is on a journey towards improved health. We have a little feedback. That gets started with our community health needs assessment, our CHNA, our community health improvement plan, our CHIP, and our strategic plan. They all worked in tandem to help us along our journey towards improved health for Pima County. The health indicators serve as our North Star to guide us along the way and provide us measurable data to tell us how we are progressing. Our community health needs assessment was conducted during the whole year of 2024. It happens every 3 years. And it serves to inform our work and help us focus on the priority areas that arise from direct community input as far as what their needs are and what the community wants. This is a collaborative effort that we partake in with nonprofit hospitals and health systems like TMC and Banner, along with federally qualified health centers and community-based organizations. And I would be remiss if I didn't mention our very close partnership with the Arizona Prevention Research Center. The AZPRC helps us collect our primary data. During January of 2024, we opened our survey and the Health Needs Assessment Survey, and we collected over 4,000 responses, which is pretty amazing. And then in the spring, we conducted a whole bunch of key informant interviews. And during the summertime, we focused on conducting our focus groups. We had 8 different focus groups and got some really, really great information from them. And then in the fall, we wrapped it up with a gallery walk that had nearly 100 participants. And that was our primary data collection. The secondary data collection was being done throughout 2024 as well, and that was using publicly available data from the census, the Behavioral Risk Factor Surveillance Survey, or the BRFIS, our Arizona Health Department data that's publicly available as well as county health rankings and other nationally available resources. So when we finally found out what our priorities were, it was like waiting for the birth of a child, but we got our 6 priorities. It was like having twins. Normally we have about 3. So we were pretty excited when this came out and we found out that we had 3 priorities under health priorities, as well as some under social determinants of health priorities. So the child and adolescent health priority was a new one for us this year, and this was directly coming out of COVID, because there were a lot of children that were developmentally delayed and socially delayed from the isolation that happened during COVID, as well as our teenagers having higher technology use and social media, suffering a lot of mental health issues. The next priority was mental and behavioral health, which is a frequent flyer here with our CHNA. But this time it was really focused on access to care, specifically long wait times and lack of providers and lack of services, in-home services. So if you were having a behavioral health crisis and you needed a bed and you needed to go somewhere for a while, you might be waiting 2 weeks or more. And that was just not okay. So we're looking at ways that we might help alleviate that. So the other health priority that we had was substance use disorder, again, a frequent flyer, but this time was focused specifically on the rise in fentanyl use and the lack of prevention and treatment services in Pima County. So the next set of priorities are social determinants of health, and I think you all know what social determinants of health are, but they're non-medical factors that influence our health. And it might not be a surprise to you that inflation and rising cost of living is on there, because it creates a lot of stress, and I see a lot of heads nodding in the audience, but it causes a lot of health and well-being issues. And along with that, accessible and affordable housing, they kind of go hand in hand. If you're having financial problems, you might have trouble getting good housing, and maybe the housing's just not available because the rents are so high. So they're kind of going in tandem there. And then roadway safety, this one made my jaw drop. It's not about the number of cars on the road. This is specifically geared towards pedestrian deaths in Pima County. It may come as a surprise, maybe not, but it surprised me that Tucson is number 3 for the highest number of pedestrian deaths in the nation. So we're trying to figure out why that is and what we can do about it. So the CHNA is done, and now it's time for our CHIP. The CHIP development happens in 3 phases. We're kind of between phase 1 and phase 2 right now. The first phase is the exploration of what's going on in the county and through the health department that is tailored to the priority level areas that have been identified through the CHNA. The second phase is where we come up with an action plan to leverage the work and programs that are happening, as well as the Pima County resources that we might be able to lend to our community partners, so that we can improve the work that's being done in the priority areas. And the last phase is writing a report so that we can let the community know how the CHIP went and what's going to be happening down the road. Does this look familiar? I remember seeing this chart, the 10 essential public health services, during my first or second year of grad school. for week of grad school. And I was like, yeah, okay, that's cool. Saw it a lot during grad school and I never really absorbed, how important this chart is. But I'll tell you that Pima County Health Department, this is our Bible. We follow this tooth, line, and sinker. And if you look at the words around the outside, it really is kind of like a three-legged stool with policy development, assessment, and assurance holding up the entire wheel. And every single one of those services that are listed in the wheel, we do. And I can probably identify a staff member that does each one. And then the whole thing wouldn't happen without a focus on equity, right? Because we need to make sure that everybody has the same access to care and services that they need. So the CHIP is developed with these 10 essential services in mind. And finally, we have our 6 CHNA priority areas and how do we gather them together to move forward with our CHIP. So we've made some CHIP priority areas by combining several of our CHNA areas into 3 priority areas for the CHIP. So we have behavioral health and access to care, the inflation and rising cost of living. We'll be looking at how access to care is being impacted because of rising costs. And then roadway safety, we are involved with the Safe Streets for All grant with the city of Tucson, specifically looking at the intersections and the dark streets and what's going on in the city that's making it so dangerous for pedestrians. So I'm really looking forward to seeing how the CHIP turns out. We're right on the cusp of getting things going, and we're looking forward to reporting back to you guys in about a year or two. Thank you.
Hello, everyone. My name is Bailey Inman. I use he, him pronouns, and I am with the Epi division at the Pima County Health Department. And I'm here to discuss translating big data into action, and more specifically, discussing congenital syphilis intervention that we've made here in Pima County. So my main topics are our health department response, and I really want to discuss just the rising syphilis burden that has increased our congenital syphilis risk here in this county. And the main message is how routine surveillance alone has not been enough. And we needed to find ways to connect our data into action here at the health department. So jumping right into some of our data, this figure shows syphilis cases from 2010 through 2024. And you can see it has continued to trend up, and we had over 1,000 cases in 2023. And since 2010, we've had a near 500% increase in syphilis cases. Obviously, congenital syphilis is a part of the broader trend, so identifying the initial cases is really important. And seeing this overall trend of the cases of syphilis rising in the county. And then here we see our congenital syphilis cases from 2010 through 2024. And of course, congenital syphilis, the definition is when a mother with syphilis passes the infection on to her baby during pregnancy. Obviously, you can see congenital syphilis continue to rise overall with the syphilis case counts. It's a very highly preventable, in fact, it's fully preventable with treatment. And it really just reflects a missed opportunity, multiple missed opportunities before the pregnancy delivery. Obviously, with the increase in those cases, we see a risk of infant mortality increasing. We see lots of issues, obviously, at hand. And you can see there in 2024, we had over 50 cases of congenital syphilis in Pima County. So why do we care about congenital syphilis? Well, I mean, that's pretty obvious, but for one, it's easy to screen for. It just needs a blood draw or finger stick. It's very easy to treat. It just needs 1 to 3 injections of long-acting penicillin. And when it's treated, we can reduce those risks, those chances of stillbirths, premature births, and permanent disabilities. Overall, it's just reflection of missed opportunities across the entire healthcare system. And so looking into things, we determined that we need to look beyond the individual cases. We really need to understand some of the systems that surround these cases and find out what do we know, who knew, and could we act in time. So overall, our key line or key issue was routine surveillance was just not doing enough for us. And this little picture, it's kind of a mess, but it shows how we were determining some of the timelines, different stages, and different processes involved in a congenital syphilis case interview, investigation, everything that goes along with that. And so looking into the big data here at Pima County, we really did a lot of work with the Arizona Department of Health Services, looking into the databases that we have available to us. So in collaboration with ADHS, we were able to look into the data coming out of the main STI reporting system, which is called PRISM. Don't ask me what the acronym is, because I can never remember. But and we took that and created our own county level registry of all of the cases of syphilis in pregnant individuals for the prior 13 years. And so using that data, we are able to identify certain patterns in demographics, housing status, drug use, just overall richer patient level data. And we were able to move beyond just the counting of the cases. This, and just so I know, this is Erin Woods. She is one of my former coworkers. She's presenting here on treatment during the bicillin shortage of 2023-2024. She did a lot of great work with the registry. But overall, this has really allowed us to take a closer look at this issue at hand, having this data pulled out into our own registry. So it's really just helping us identify what barriers are being missed. Were they missed before delivery? You know, would this have been a preventable case? And you know, who specifically is being missed? So it's been a great addition to our overall attempts at curbing the spread of congenital syphilis. And this shows just one aspect of that data. So it helped us look into the incarceration status in the last 12 months, reported self-identified by the individuals during the investigation. And you can see that number where 24% of patients patients who were identified reported having been incarcerated in the preceding year. Obviously, that's a large percentage, and it shows there's one area where we could, you know, interact with our you know, resources in the county. And so it's really helped us link in with the PCHD, that's the county jail. And we have a really good relation with the individuals who work there, and we're able to communicate with them. They're able to send things over in real time, ask questions about titer statuses, histories of syphilis, and everything that goes along with that, and finding out, you know, right then and there if this individual needs to be treated. This registry really did help us identify just all of these cases, and it showed that big number there, that 412 syphilis cases were identified in the last 13 years in pregnant individuals. 2013 through 2019 only had 76 cases, whereas 2020 through 2025 had 336 cases. Obviously a very large increase. That also helped us look into the social determinants of health risks, where 95% self-identified as white, 95% spoke English, 75% reported housing instability or homelessness, and 70% also identified recent use of fentanyl or methamphetamine. And a very important piece that we discovered was among those with minimal care, more than half of these pregnant individuals had at least an urgent care or an ER visit during their pregnancy. So that really helped us identify one specific area that we could target. So again, those more than half received care in that urgent care or emergency department. And so we started to ask ourselves, what can we do to help? This is, a big issue and easily preventable. So what we were able to do was work with our partners at a regional hospital here in Pima County. And we are working on this pilot where all pregnant individuals being seen in the ER for any reason would have opt-out testing conducted for syphilis antibody screening. And then if that rapid syphilis test was positive, then the ER staff is being informed that they can reach out to us directly. Anytime we have individuals who answer the phones, during regular business hours, but we also have individuals who answer after hours, because obviously a pregnant case of syphilis is very important. That is worthwhile to reach out to us after hours, and we can find out right then and there if this individual needs bicillin right then. And it really helped us look at some of our main goals, these 3 goals, where it would help us identify more cases by screening in the EDs. Sorry. It would help us initiate treatment of these new cases, and it would help us link these patients into care. Obviously, by having direct interactions with the emergency department, these cases could, in real time, or if not real time, then at least linking directly to one of our investigators, just different ways, different pathways to get this individual into treatment. Not every emergency department has bicillin on hand. There's current shortage again, but our health department does. So getting them into that care and getting them bicillin as soon as we can is really important with these situations. And another thing was how the registry that was developed opened these new doors. So standard interview questions for a new syphilis case always included, are you pregnant and when is your due date? But by using this registry, we were able to take that data from the reporting system and look into the active intervention. So here's a screenshot of that, part of that registry, de-identified. And some of that data that's entered in by the investigators is now pulled out, and we are looking ahead, and we're able to see, again, these individuals who are pregnant and will be delivering in the future. And, getting us this line item data where we are able to have our different partners at the health department or in the community directly interact with these individuals and get in contact with them and get them in for screening and further testing and further treatment. And that registry is automatically updated several times per week. Like I said, we can identify those diagnosed while they're still pregnant and provide that intervention immediately. There is also another program here at the health department, and just a shout out to one of our providers, Rachel Gordon. She has really worked hard on this project. It's called the SPOTS program, which stands for Syphilis Pregnancy Partner On-Site Treatment Support. So what this is for is to increase access for those pregnant individuals and their partners by allowing one of our providers to go out in the field, meet with this individual and get them treatment where they are. So that could be treatment at their home. Maybe they don't have transportation available to them, or treatment out in the field where, maybe we're able to find some sort of private area, but we do have a lot of individuals who are unhoused, and getting them that treatment. Again, there's a lot of barriers to that. So getting someone out there with the bicillin in hand has been very important. And just of note with that SPOTS program, there is a form that is available online that is for providers, and they can fill that form out. If you look up the SPOTS program for Pima County, you'll find that form. And providers can fill out that form and request that one of our Pima County providers go out and provide that treatment to those individuals. And just in closing, this is some of the program impact. So these are the case counts for congenital syphilis from 2020 through 2025. And the early impact overall looks very promising. So in 2025, we counted a total of 28 congenital syphilis cases, down from 51 from the previous year. Now, of course, we do interpret this cautiously because this alone does not prove causality. But again, we have had these interventions in place for several months now, and 2024 was when we really started working on some of these projects. 2025 is when we were really trying to implement a lot of these, and we really developed a more responsive system. We can identify these cases earlier, intervene before delivery, and we just, like I said, we determined that surveillance was not just enough. We needed to expose these missed opportunities for treatment and care. And in closing, congenital syphilis is fully preventable. And we really just need to build these systems out to act early enough to prevent it.
All right. So I'm Betsy Camara again. I'm with the Office of Heat with Pima County Health Department. So we at the Office of Heat Relief and Response do exactly that. We respond and to heat and try to make the most vulnerable populations less vulnerable. We get them the help that they need. We get them resources that they need to keep themselves safe. So I want to talk about applied public health. So you all might have heard this term in some of your coursework, but really we're translating public health theory and research into the real world practice. So this might be through community engagement, health promotion, disease prevention, implementation, or best practices, lessons learned kind of work that we do. So a lot of what we do at the health department is the applied public health. So we're bridging the gap between the academic knowledge and turning it to real world health solutions. So yeah, it's really cool to study all of this stuff, but it's even cooler to take what you study and see it in real world and see what works and also what doesn't work. Because each community, each population that you work with is unique. And so it really just depends on how we see and work with them. So I want to see what you all can do. If you can do my job better than I can do my job. All right. So imagine that you are me, a program manager for the HEAT program. What are you going to do? Step one, we need to understand the problem. So what do you see? What is the data telling us? So I'm going to show you some graphs here, and I want you to shout out what you see. What do you see?
Heat deaths.
Thank you, Bailey. So there are more outdoor heat deaths than indoor deaths. Is that surprising to anyone? No. All right. But how we still have 42% of indoor deaths. It's not 100%, right? So we are seeing a vulnerability there, okay? What do we see here? More male deaths, exactly. Is that surprising to anyone? I see mixed heads. Okay, all right. And the last one, heat-related deaths by age group. What do we see here? I know there's a red line up there. I don't know how to get rid of that.
Higher age, higher death rate.
Exactly. So higher. So almost 52% of our deaths are older adults, 65 and up. So when you take all three of these things, older adults, outdoor versus indoor, and male, do we see maybe a target population coming out of the woodwork? Okay, I'm seeing some head nods. All right, let's look at some more data. So this is trend data. So we're looking at 2023 to 2025. So looking at time, we see heat caused versus heat contributed. Does anyone know the difference? I know Harrison knows the difference, but does anyone else know heat caused versus heat contributed? So heat caused means heat was the cause of death. That is what's on the death certificate. Heat contributed is heat plus something else. So that might be heat plus cardiovascular disease, heat plus hypertension, heat plus substance use disorder. It might have something else on there or overdose. So that's what heat contributed means. So what do we see looking at heat contributed? That's the orange. Do we see a trend? I know this is not statistical significance, so all you epi people just ignore that for now. But do we see kind of a trend in the numbers? Probably not. It seems to be pretty consistent if we're looking maybe at percentages, but heat caused death. Do you think we can see a trend there? Yeah, that seems to be trending down. So that's a good thing from what I know from what we did at the health department. But why do you think we maybe saw a trend in heat caused? Has anyone seen our Beat the Heat campaign all over Pima County? Some of you? Okay, so we have done tons of outreach to unhoused populations, which is our primary people, our primary target population for heat cause, because they're most at risk for outdoor deaths because they don't have access to air conditioning and they're living outside, right? So that's why we kind of see this trend. Again, quoting Bailey, we can't prove that this is causation versus correlation right now, but we do see this trend. Heat contributed, however, there's something else going on. So what we need to do is focus on this population, okay? Next, we're looking at annual unhoused heat-related deaths. So I kind of already spilled the beans on this one, but you can see that our trend is going downwards. Yep, so we see 45 to 32 to 28. So we are seeing a trend downwards with that data. And now looking at annual heat-related deaths by location in Pima County. The bottom portion are indoor versus outdoor. Do we see kind of a trend here? Yeah, outdoor is going down a little bit. Exactly. So again, maybe our outreach is working towards our outdoor target population, but indoors, we really need to make a difference here. And then some more data to look at. So primary cause of heat-related deaths. So this is all heat deaths, regardless of heat contributed or heat caused by the primary cause of death. So we have, again, heat caused, and then the next is substance use, chronic disease, and then other. Do you see any trends here in the data? Maybe not trends, but points of interest. What do you think about that chronic disease category? So this might be hypertension, this might be cardiovascular disease, this is also could be diabetes, it could be a bunch of other things. What are people on, or what are people maybe taking when they have a chronic disease? Medication. So we're trying to understand what is the relationship between medication and heat, right? And so this is why we're so focused on that in this upcoming year as well. Also the substance use numbers. Does that surprise anyone? Does anyone know why they might be vulnerable? If you're intoxicated, do you remember to drink water? Probably not. So of course, there's a lot more into that, but it's one of the things that we're starting to look at as well. So yeah, heat caused is going down, but all these other things are increasing and looking worse and worse every single year. And the last one, primary cause of heat-related death in Pima County based, again, on their primary cause. And we just break it down into the different categories. So heat hypothermia is the first. So we've had 110 deaths in the past 3 years, but the next highest is cardiovascular disease. Next is methamphetamine use. Next is polysubstance use, and then hypertension. So cardiovascular disease, hypertension is among the highest. There are about 87 cases related to those two. And then we go down and down and down the list. So now that you've seen the data, what do we do? So what would you address first? I saw a hand up briefly in the back. Yeah.
Yeah, sure. I guess like across all the different data, because you looked at men, older adults, I would look at the highest number of deaths, and I would try to focus on that impact first, so that I get more funding, support, and advocacy, and focusing on the population.
Good. Okay. Anyone else? All right. How would you address it? So if we're looking at the highest cases, the highest incidence, the highest number of people that are most affected by heat, who would that be? Do you remember from the graphs? So it's probably men that are 65 and up, and they're outside. So how are you helping those people? How would you address it?
Go to them.
Go to them.
Yeah.
Okay, so you might do like a focus group to understand what's going on. Okay. What else could we do? I'm comfortable in silence, y'all, so I'll keep waiting.
With your older age populations, PCOA.
There you go. So work with community-based organizations, other nonprofits that are already working with these individuals. Good. Okay.
Do you know if they're outside by choice or by circumstance? Like, is it like their job and they're outside, or is it their shelter?
Good question. We actually don't see that many work-related incidents. We do have a couple. We've seen more heat-related illness cases, so outside of deaths. So they haven't gotten to that severity yet. So most likely not work-related. Most of these would be retirees. I feel like I kind of tricked you. So if we're looking at 65 and up in male populations, it's most likely indoor deaths. So that's kind of a misnomer there. So if we're looking indoors, what might we do? Yes.
I mean, one thing I come to learn about heat indoors, but not everyone has access to quality AC. And so I try to understand, maybe again, it's like focus groups or screeners and things like that, either CEOs or directly, do you have access to AC, how consistently?
Absolutely. Good. So where might these people be living if they don't have regular access to AC? Again, I might be asking to jump to conclusions, but what do we know about seasonal visitors, about what we call snowbirds? Where do a lot of them live? If anyone knows anything about that population. Yes. RVs, mobile park, exactly. And has anyone ever been in an RV in 115-degree heat? You are cooking. It is an oven in these places. So if that person is on a fixed income, a low income that's fixed, they might not be turning their AC on enough, and they might not have sufficient cooling. And because they can't afford it, they don't have a choice, right? So they might not be able to turn on that AC for as much as they can. So how would we address that? They can't turn on their AC. They don't have funding. What can we do? I thought I heard it. Say it louder. Cooling. Thank you, Maya. Cooling centers. So we can open up cooling centers. How do we get people to those cooling centers? Are they walking? Are they taking the bus? Are we providing them transportation? Who's paying for those services, right? These are all questions that we circle every single day trying to figure out, okay? Who will you work with? So we said PCOA, some of our profits are community-based organizations. Who else might we be working with? Sorry about that. Who else are we working with? How about you all students? We love working with you. Yes. TEP, good. The electric company, right? So they might be able to do some low-income programming. That's a good idea. How about neighborhood associations, mobile home park owners, mobile home park associations, some of these people, right? We also might be able to do messaging, just outreach campaigns, flyers, mailers, all of this stuff. And we can work with our local post office. We could do check-ins with neighbors, right? The Red Cross, we're doing outreach with the Red Cross. There's a bunch of different opportunities to work with this population. What would you measure? How are we going to look at the success of this? Well, we could look at the data that we've already seen, right? But like we kind of mentioned, there's not a great way to measure causation versus correlation, right? So we can only make assumptions about what we're seeing. What else could we measure?
Talk to, how many
Great.
people using these cooling centers.
Great. Yeah. And maybe demographics of those using the cooling centers. Okay. Are we reaching the right people? Are they showing up? Yeah, Lord.
Hospital discharge data.
Good. Hospital discharge data. Yeah. So for illness understanding, or even the death rates, really understanding who's showing up, what are we seeing in the data, what are we seeing in the trends? Yes.
Qualitative data too on like how cooling centers or interventions have impacted people.
Yeah. Great. Cool. And then what resources do we need to do this work? Money? Probably need some money. We probably need some staff to do the work. Probably need, we're gonna do transportation, maybe some grant funding or like transportation services, reimbursement processes, right? What else? Good. Locations, right? Exactly. Staff at those locations, if they're volunteers, are we supporting them with resources, supplies? How are we supporting those centers? Okay. If we're doing messaging, do we need someone to develop that messaging, right? Communications, development of education materials, maybe research on what works best with those education materials, right? All right. So now the last step and beyond is you just need to continue to ask yourself, what else should we consider? What else is needed to make these decisions? What are we missing? What gaps are there? What can and can't we accomplish? Right? There's only so much we can do. To give you reference, it is me and one other program manager, and that's it for the Office of Heat for all of Pima County. We have amazing partners at the U of A. We have amazing partners at the City of Tucson. And all of our nonprofits. We have a lot of volunteers that help us run the HEAT program, but it really is, it takes a lot of dedication in order to run a HEAT program here in Pima County. So thank you all. I would hire you all in a heartbeat. Appreciate your help with this. But this is kind of what we did at Pima County Health Department. So last year in the 2025 heat response, we increased our outreach, like I mentioned, to unhoused encampments, to mobile home communities. And so that's why we think we see this trend downward with our heat caused deaths. We increased coordination, so we brought all the right people to the table, so we're not all siloed in the work that we're doing. We do weekly partner meetings. We have a joint technical team that we work on with HEAT. We all get together, we all brainstorm together, we all work together to accomplish this goal. It can't just be one office. It just can't be one program doing this work. We increased our messaging about heat-related illness and cooling center access. I mentioned the Beat the Heat campaign. If you haven't seen it, we're really proud of it, and we get a lot of community feedback that it's really helped in the community. Look us up. It's just a great resource. There's also a bunch of free resources out there. And then we're looking just beyond heat risk into the social determinants of health and other factors contributing. So it's not just heat is the problem, it's housing is the problem, utility access is the problem, affordable living. All of these things are contributing to heat deaths in Pima County. So we really want to contribute those and consider those when we're planning. And then looking forward to 2026, we're continuing our outreach, right? We can't just stop. Now that we see these trends downward, we have to keep those up and add on our other target population. So we're trying to get to more encampments. We're trying to do more mobile home canvassing, but we're also starting earlier. We've had our first heat outreach yesterday. And I don't know if you all heard, we're in a heat warning, a heat watch happening. So we're kind of just in time. We thought we were about a month ahead, but now we're just in time for heat happening. But we're just continuing our coordination. We're expanding our partnerships. We're trying to reach out to people already doing heat relief. So that might be our church groups. That might be our CBOs. That might be people in the community that go for resources, right? We're trying to incorporate them into our network and getting them resources. We have water, we have electrolytes, we have cooling towels. So how can we get the resources to those working, to those people, to those organizations already working with people in the community? We are trying to focus on heat contributed. So this is our cardiovascular disease prevention, heat, like educating about educating about heat vulnerability to this population. We're trying to focus on working with providers and pharmacists about their education to these populations. As soon as you're on a heat vulnerable you're on a medication that makes you heat vulnerable, we're giving you the education right then and there, so you know that you have to take extra precautions. So we're trying to set up these things so that it's prevention based and not a response based. We're trying to build in long-term sustainability, so green infrastructure, home weatherization, trying to make mobile homes more summer friendly, for lack of a better term. We're trying to make these places safer for people to live in. So they wouldn't have to use a cooling center because they might not feel comfortable going there. So again, trying to find the source of the problem and fixing it. And then again, continuing to contribute the social determinants of health as key factors and opportunities for intervention. So on that note, join us this summer. We actually have 2 graduate interns with the Office of Heat and 1 undergraduate intern. So spread the word. We would love to have you. This is what you're doing. Jill can attest to this. She was our amazing intern last year. But we show you what we know. We give you the information. And then you run with it. You build your plan, you build your program, you build your intervention, and you do it. And we support you along the way. So it's a really great way to get hands-on learning and hands-on practical experience of how to use public health in the real world. And then we actually have 1 other graduate intern with the epidemiology division that will also be working on with heat, but you'll just be working with the epi team on that. And then I think there's 9 other positions open at the health department over the summer. So please apply. They are paid positions. They will be 40 hours a week though. So it's a full-time internship. Just keep that in mind. But we are very accommodating to vacations and schedules and everything. So we would love to have you. And then, yeah, if you go to pima.gov/jobs, you'll be able to find all of the postings. And then, yeah, contact us. If you have questions, if you want to hear more about what the internship process would be like, if you want to tell me how to do my job better, I love it. Call me, let's chat. So here's my contact information. We would love to get in touch, or you can email heat@pima.gov. So yeah, thank you so much. We appreciate your time. Sorry for overtime a little bit.
No, thank you so much. Wow. There's such a great, showcase and demonstrate how you can apply what you learned from the school and to the public health field. And we know people working diligently around to prevent death, prevent injury, prevent diseases. And thank you so much for the important work you have been doing. And you also see a good model of Laura and from our program now is working with the health department, a lot of opportunities for students to join them. And opportunities for internship sometimes can also lead into possible jobs. Yes. So do check out that site and contact them. But now we're open for questions.
We have one online.
Online.
This question is for Ms. Vitkus and Mr. Inman. Could you tell me what measures you take to ensure that the data collected is credible? Questionnaires can be tricky and highly subjective, especially when working with individuals with developmental disabilities, minors, and memory care clients.
Obviously, data cleaning is very important. Our investigators, we have a great team of communicable disease investigators. Those are the individuals who collect a lot of that data, conduct that outreach to these individuals and conducting those investigations. So, with any sort of investigation process, we're taking a person's word for, their answers to these responses. But overall, we don't necessarily have an issue with we don't often run into situations where someone's going to not have the correct info that is going to prevent them from getting treated. We're going off of the actual data showing, hey, this person had a 4-fold increase in their syphilis titer and this person needs treatment. That's just a fact. So again, the data cleaning happens during the interview and it's just part of the training process. So our CDIs are good with that.
Yeah, this is a really good question. For the community health needs assessment, we partnered with the experts here at the University of Arizona Prevention Research Center. So they did all of the data cleansing and collection and assessment of the data. But as you noticed, we also didn't just do a survey, we also had key informant interviews, we did 8 focus groups over the summer, and also did a gallery walk. So I think having that wide variety of primary data collection kind of helps cleanse the data all as well. Yeah.
I have a question, a general question to the panel. Great work, very interesting. I think, yeah, it's inspiring to hear this, but then also to think about like how things are getting worse out there. Like heat is going up, people are losing resources, and you know this like advocacy for like getting that done is great, but at the same time, when all these things are being taken away from people for like access to resources, so I'm wondering if like within your work. Do you see like pathways to like implement policies or to influence decision makers to implement safety nets or safety resources to say like, hey, they'll have it like allocate more resources to these people, or you know, not increasing energy costs on like mobile homes or something like that. Do you see in your work that you're doing, do you see those like that momentum moving toward that? And I don't know, any kind of inspiring word would be helpful too.
Yeah, I can say something. So obviously our EPI team, we're big on the data side of things. So we'll use our data to help influence policy changes. So making sure that we have good data, like I was saying before, obviously is very important. So we kind of take that back end, turn it into something useful for those who do influence policy, and just kind of go from there. I mean, we work with a lot of different divisions across the health department. So I know we do a lot of work with Pete, my work with Cheyenne has done a lot of work with that. And we're all across helping each kind of area with data requests and asks and digging into the background of some of these issues. So we kind of start from the backside and help with the policy changes.
This is a really good question as well. What comes to mind for me are the changes that are coming up around Medicare access, beginning in 2027. So, my personal experience is that, at least in my small team, we've been trying to attend the national conversations that are happening and having those conversations early. I mean, it's still early in 2026. We've got most of the year to plan for this, but really staying tuned with what the whole country is talking about as far as making those preparations for those changes.
Yeah, and I guess with heat, because we have such a coordinated effort among all of our partners, we might not be able to be at the forefront of policy, but we can help inform those policy decisions. And so we have a lot of local, like there's a mobile home task force group, there's a mobile home advocacy group, and so they're just trying to use our data. Basically, we give it to them to help them kind of argue their case that there needs to be these policy changes in order to create long-term sustainable changes, given the context politically. And I think just maybe not a positive note, but like that funding is just going to get more limited for a lot of these factors, and so we have to pool resources. We have to use work within existing agencies and coordinate together in order to get the work done. And so it is a testament that other programs could be as coordinated as HEAT, or could be as coordinated as like working on congenital syphilis. Like that is the model moving forward. And so working with local health departments, local governments across the board is what's going to really make those changes. There's so many.
Yeah, in the way back. This is a question for you, Becky, actually. Looking at heat is sort of a One Health issue too. And a lot of, indoor issues I think can be related to having an animal that they don't necessarily want to leave. How are you all addressing that, or how have you found developing partnerships with, more animal homes for that kind of thing?
Absolutely, that's a great question. So we work with Mona and a lot of our partners at U of A, so they're more focused on the One Health. As you can probably tell, there's a lot of different issues we could work on, so we need our partners quite prevent makers and other things. But we are trying to make cooling centers more pet friendly. We're trying to give them resources and training and access to cleaning supplies and giving them crates if that's necessary. Like we do everything as much as we can to make them pet friendly places, so that people don't have to choose between themselves and their pet, because most times they will choose their pet, as we see. So we are trying to make those spaces more accessible. And then maybe coming up, there's, again, this is so long term, not long term, but this is more future thinking is maybe we can do some more outdoor spaces that are more pet friendly, so making like having cooling towels or towers, or doing more like evaporative cooling options that are in shaded areas, so people again don't have to choose between themselves and their pets. So not a solution now, but it's on our radar for sure, and it's something that we would love to focus on in the future. But we also, through the health department, have our healthy companions. I don't know if you've heard of that. So we also partner with them and trying to get them to show up at some of our cooling center locations. So it also builds that connection and builds that relationship.
Interesting. One follow-up, of course. So I'm a veterinarian, and I know that's a great point to be able to talk with a client who's coming in, even a snowbird client who's your friend of the year, to say, let me refer you to the cooling center. You do any outreach with, say, private clinics or that kind of thing? We give them resources to give to owners?
Currently, but that's a great idea. We would love to do that. We do have, we last year created like a pet friendly cooling space card that we give to, a lot of people as they ask. So if they show up to a cooling center, like a library, for example, and they're not allowed in, they're given this card and then they can get referred to other places. So yes, we would, that's a great idea. We can reach out and try to refer, or get that information to the clinics. Sure, that's a great idea. Thank you. Yeah, thank you.
Can I jump in with an online question? Regarding congenital syphilis, how has the shortage of bicillin LA impacted Pima County, and have you seen any effect on congenital syphilis rates?
Definitely, we've definitely seen, differences with, treatment and, unfortunately, we've seen multiple different shortages. Where we saw a shortage in 2023, 2024, we overcame that. And then, of course, we're in another shortage now. So our clinics are doing a great job of, a word I think was hoarding what we have, and keeping it for those individuals who are pregnant, or the partners of those who are pregnant. So the shortage has definitely impacted some treatment options, but we can't be giving doxy to those who are pregnant. So by having that bicillin available for those pregnant individuals, that's why we're really trying to push providers in the community that the department has access to bicillin available, willing to go to people's houses and give them that injection or 2 or 3 injections, from our stockpile. Because I know a lot of the community partners do not have access to bicillin, and so they're referring to us. And again, we have it available to those who need it, and we'll get past this shortage. Unfortunately, I think we're looking at I think later into this year, possibly into 2027, but I want to say later this year, might be the end of the current shortage, but fingers crossed on that. I know there's other options like methicillin. I don't think we have done that at the health department yet, but if it were to become a massive issue where we had no available bicillin, there are some alternatives that we can turn to. But yeah, it's a good question because it's definitely had an effect on treatment options for the pregnant infants.
Thank you.
For Bailey, what were some of the challenges that you saw with data? How did you maybe address?
Yeah, I mean, starting from scratch with some of that, just looking into who these individuals are and pulling out pieces that are kind of hidden in the investigation forums and data and everything like that. There's lots of different areas where we capture certain pieces of data and just finding a way to kind of gather it all into one space and look into these future issues where these individuals have been already identified as being pregnant, and finding actionable items that we can do to prevent another case of congenital syphilis. Has been really, it's been really useful having access to this type of registry. So I didn't do all the work on that. I cannot really take credit for it. It was definitely my coworker, Erin Woods, who really did a lot of work on that. So she really helped build out a significant project. Our medical director, Dr. Saul, assistant medical director, Dr. Saul, he's been doing a lot of work with that registry specifically, and he'll even take portions of that registry and provide it to some of our clinic providers, and have them follow up on a lot of these cases and reach out to these individuals, and of course the investigators are still doing that, but we have multiple fallbacks for getting these people into treatment. So, but just having that data available has been a big help for getting these people treated.
Great presentation, it's been great. I just had a quick question on the community health needs assessment. I was particularly interested if I'm wrong, that they're conducted once every 3 years. How consistent are the main target areas like identified across those? Like I can imagine behavioral health probably pretty consistent, but something like road safety, like is that an emerging topic or has that been there for the last?
That's a great question. So mental and behavioral health was a repeat from the last time, as well as substance use disorder. The last time that mental and behavioral health was focused on suicide, and the substance use disorder, I think, was on opioids. So it has a little bit of a different, specific focus, but they are kind of frequent flyers, and like the child and adolescent health is the new one this time. Roadway safety has come up in the past as kind of a secondary priority. But it's nice to see that this time around that they're really asking for, us to work on that. Yeah, that's a great question. How about you on the left? My left.
So I guess in terms of the community needs assessment, key priorities, are the ones for Pima County different than the ones that ADHS have set out, or maybe Maricopa County?
That's a really great question, and I don't really answer because I'm so focused on my own.
Okay, like kind of in like the same vein, but when you were looking at like ADHS like prison data, what was that like reverse engineering process like? Do you stand on that, and do you feel like there were any variables that you felt were that you wanted to like see or like analyze specific to Pima County that was maybe like missed?
Yeah, so like I again can't fully take credit for all that work that was done on that data, but I know some of those variables, they've always, not always, but a lot of them have existed in the data, as a whole. One of the issues was just not really having anyone looking at it. So over the past 3-ish years or so, our team has really built out, you know too, so having more people looking into this data, more EPIs, more people conducting the actual investigations themselves, and having more complete data too, because at a certain point, certain investigations, again, of course, the pregnant individuals are high priority, but not every case can be investigated because sometimes the burden is just too high. So having expanded our STI investigation team, as well as having individuals who are looking into all this data, that's been a big help with just kind of developing everything with these processes. And so with the reverse engineering, interesting phrasing, but we have, like I said, always kind of had some access to some of this data. The state has provided more and more variables in some of the extracts that they give to us, but some of the really important ones to look at were like what I mentioned with housing status, and substance use disorder, and just helping us target those areas, those problem areas where some of these cases could be found, and providing outreach to maybe certain clinics like methadone clinics, or maybe even we've talked about providing outreach to crisis pregnancy centers, because some individuals have reported that's their only prenatal care they receive their entire pregnancy course. So just trying to identify those places where these individuals might be found, even if it's just the one time they might be found, because some of these people, like I said, they just fly under the radar the entire time, throughout their entire pregnancy. And, if we're able to just latch on to just that one spot where they might have been caught, then, we can potentially prevent that case.
In the cream sweater.
Thank you so much. I guess it's up to all of you, and if you can give examples maybe from your work. So if you could describe and talk more about the partnership or relationship between the Pima County Health Department and maybe the state health department, even on the level.
Yeah, we do a lot of back and forth with the AHS and the Epidemiology division. So I communicate a lot directly with their STI team. That could involve syphilis, that can involve HIV or other morbidities. But we definitely interact a lot with those EPIs and investigators up there. So a lot of good teamwork, and their team has really helped us a lot. They have a lot of good ideas, a lot of good, pathways to success. So the interaction we have with the is so positive, but very helpful.
I would say the same for my office too, and aside from that, we use their data all the time and refer to their data. We also sit on coalitions together with the statewide and national level agencies. Statewide, what comes to mind is the Falls Prevention Coalition, that we have a Pima County component that they operate out of the ADHS Falls Prevention Coalition, so very tied in with them there. And then just national organizations. I personally just went to St. Louis last week to participate in an evidence-based public health training through Washington University in St. Louis. And they're doing that at the national level too. So as any chance we can to get to collaborate with national and statewide agencies, we take it, sure.
Yeah, and talking about heat, we work with the AHS quite closely. They kind of let us know how to activate into response mode if that is an option for us. But we also work very closely with Maricopa County Department of Health, as well as all the city governments throughout Phoenix, as well as the city governments in Tucson. So we all kind of work together. We're all trying to accomplish the same goal of reducing heat death and heat illness all throughout Arizona. So we do a lot of coordination. We all share resources. We all share education materials. We all kind of collaborate together on projects to make it successful. And then I think a lot of the other programs, divisions do the same, like I mentioned. We're all working together towards the same goals, and we all see a similar thing. Federally speaking, maybe not so much for heat because we are so specific. I mean, we might take resources from like Southern California, who has a similar climate, or New Mexico, as well as like how they respond and react to emergencies. Like that might all be cross collaborative, but like a heat wave in the Midwest is not the same as a heat wave in Arizona, so it's not so much translatable outside of the Southwest. Yeah. Thank you. Yeah, I'm back.
For the congenital syphilis, kind of, are you seeing the same trends? And then, is the treatment for syphilis, is the treatment for syphilis kind of contraindicated with any substance treatment?
So the treatment for syphilis usually either involves doxycycline or long-acting penicillin. So not that I can think of on top of my head any issues with substance use, but always good to know a person's background with medication. And I'm sorry, what was the first question? Yes, we've seen a lot across the entire state. I don't recall the exact numbers, but I do know that back to I think 2023 is when Arizona was, I want to say number 3 or number 2 in the nation for the highest rates of syphilis. So it really just kind of kicked us in high gear with really we can get this under control. So that it includes every county, let alone not just Pima County, but Maricopa is a lot bigger, and obviously we have a larger team, but a much larger population. So we're definitely seeing similar rates We do work with them as well and communicate with them, and we do share resources and that, so they're also good with the facts I get talking about.
Thank you. There might be continued conversation and, to all the students. So let's give a round of applause again. Great job. And, we'll see you next time. For next time we'll be having the School of Health Professions.